Hi everyone, Nurse Jenny here from Nurse Life Academy, and I will be reviewing renal questions and concepts that you must know for the CCRN exam. I will time mark this video, so feel free to just scroll through at your own pace, but I do give extra information and explanations after every question to really reinforce the content. I would greatly appreciate if you like and subscribe to my video if you found it helpful, and I really appreciate all of the support. So without further ado, let's get started. Question number 1. What is the best lab test to evaluate a patient's glomerular filtration rate? A. Blood urea nitrogen, or BUN. B. Serum creatinine. C. Urine creatinine clearance. Or D. Serum amylase. The answer here is C. Urine creatinine clearance. A 24-hour urine collection test for creatinine clearance is the best indicator of the glomerular filtration rate, or GFR. So let's talk about acute kidney injury in a very general sense here, and we'll break it down into the 3 types as we go through this video. The official definition of acute kidney injury is an increase in serum creatinine by greater than or equal to 1.5 times the baseline within 7 days. Creatinine is a better indicator of renal function than the BUN, and a normal serum creatinine is around 0.6 to 1.2, which differs a bit depending on if you're male or female. So acute kidney injury is a sudden decline in the ability of kidneys to filter waste products, and it results in an abrupt decrease in the GFR, or the glomerular filtration rate. And GFR is a measurement of how well the kidney is working. It tells us how much blood the kidney filters per minute. And just like we saw in this first question here, a 24-hour urine collection for creatinine clearance is going to be your best indicator of the GFR. Something of note here is that GFR is inversely related to the serum creatinine. So if you have a high serum creatinine, your GFR is going to be low, and this means that your kidneys are not doing a good job filtering. There are a lot of people at increased risk for kidney injury. This includes patients with diabetes, hypertension, chronic heart failure, and older adults, all of which we see on a daily basis in our ICUs. An acute kidney injury results in retention of metabolic waste, fluid overload, electrolyte imbalances, and acidosis. So it's apparent that kidney injury causes a lot of problems. It's going to be very important to prevent and to protect. So we need to provide adequate hydration, adequate perfusion to the kidneys, and stop or adjust nephrotoxic medications to give patients the best chance to protect their kidneys. Question number 2. A 78-year-old man presents to the ED stating that he hasn't urinated since yesterday. His BUN is 84 and creatinine is 6.8 with no previous history of kidney disease. The physician suspects postrenal AKI, which you know might be caused by which of the following? Is it A, shock, B, azotemia, C, hypoperfusion, or D, urethral obstruction? The answer is D, urethral obstruction. Let's start by talking about post-renal failure, which is usually the easiest type of renal failure to understand and to treat. So post-renal failure is attributed to an obstruction in the flow of urine at some point between the collecting duct in the kidneys and out of the urethra. And if you look at our picture on the side here, we have our kidneys, which connect down to the ureters and then to the bladder, and lastly, the urethra. So if there is an obstruction anywhere through that pathway, you will have post-renal failure. And this can happen with ureteral blockages, such as with renal stones, urethral blockages, such as in BPH and prostate strictures, neurogenic bladder, or tumors. And you will see anuria generally in these patients, as well as a high BUN and creatinine levels. The treatment is going to be to identify the cause and treat the obstruction. And it is important to be prompt with our treatment and to not ignore it, because post-renal failure can progress into intrarenal failure if it's not corrected. Question number 3. A patient had a cerebral angiogram. Which of the following is a priority to monitor? A. Serum creatinine. B. Mean arterial pressure. C. White blood cell count. Or D. Liver enzymes. And the answer here is A. Serum creatinine. So when getting an angiogram, an arteriogram, or any kind of IV contrast dye for a procedure or a test, it can cause kidney injury. So it's going to be very important to monitor serum creatinine and to hydrate, ideally before and after, with hydration before the procedure or test being the most important of the two. Now, when it comes to IV contrast-induced nephropathy, prevention is going to be key. So protect those kidneys and hydrate before administering contrast dye. Some people at higher risk include those with pre-existing renal insufficiency, dehydration, diabetes, heart failure, patients that are taking NSAIDs, ACEs, or metformin. And you'll see signs of anuria, elevated levels of BUN, and specifically you want to monitor that creatinine. As far as treatment goes, prevention is definitely key. So before taking every single one of your patients for contrast CT scans, angiograms, and arteriograms, you want to evaluate the risk and benefits of getting these tests, which is going to be very important. And if a scan or procedure is necessary, you want to hydrate the patient before and after the procedure. But keep in mind that hydrating the patient before getting the contrast dye is going to be more beneficial for them. You also want to be sure to avoid nephrotoxic medications. Question number 4. Your patient is scheduled for dialysis at 10 o'clock today. They have numerous medications scheduled for 9 o'clock. You should A. Hold all the morning medications until after dialysis. B. Administer all the medications. C. Collaborate with the dialysis nurse regarding which medications are affected by dialysis and which are not. Or D. Give only the cardiac medications. The answer here is C. Collaborate with the dialysis nurse regarding which medications are affected by dialysis and which ones are not. Hemodialysis is used for stable patients who meet one or more of the following AEIOU criteria. And A stands for acid-base imbalances, specifically metabolic acidosis. E stands for electrolyte imbalances. Hyperkalemia will be the most common electrolyte imbalance we're concerned about. And following along with that, we would also see hypermagnesemia and hyperphosphatemia. I stands for intoxication of toxins, most commonly aspirin or salicylate overdose, which will require immediate dialysis as these patients get extremely metabolically acidotic. O is for overload, as in fluid overload. And U is for uremia, meaning waste product buildup in the blood associated with mental status changes. So any of those might be indications for dialysis. The actual process of dialysis includes filtration of waste products and fluid through an artificial kidney machine, aka your dialysis machine. And hemodialysis is done intermittently for a period of about 2 to 4 hours at a time, depending on how well patients can tolerate it. Depending on your cause, dialysis may be every other day, or they could dialyze a couple days in a row, especially in acute situations if needed. And since this process is generally 2 to 4 hours, it does a lot in a little bit of time. And it creates these large pressure gradients with large fluid shifts in the body, so it's only used for stable patients. Dialysis does require central access, so either a temporary double lumen central line with return and access lines, a more permanent tunneled central line, an AV fistula, or a graft can be used. And it's important to understand which medications get filtered by dialysis because some of them don't. So we would hate to give all of someone's morning medications just for them to all be dialyzed out an hour later, and then they would no longer reap the benefits of those medications since they're no longer in their system. Dialysis certainly can have complications. One of the most significant ones is going to be hypotension. So again, with these large fluid shifts, you are taking about 200 milliliters of blood volume and you're displacing it externally through a circuit. And that can drop their preload, which can then drop their blood pressure. This is why hemodialysis is done on patients who are stable and can tolerate these massive fluid shifts. You can also have dysrhythmias from electrolyte shifting and imbalances, filter clotting, or air embolism. Another rare but potential side effect can be what's called dialysis disequilibrium syndrome. And this is where there's a rapid pull-off of urea nitrogen, and that leaves an imbalance of urea on one side of the blood-brain barrier versus the other. So your patient can experience neurological side effects such as confusion, headaches, nausea, restlessness, or even coma. It will eventually equilibrate over a few hours, but this is something that you want to watch out for. Question number 5. Hemodialysis was just started on your patient. Their blood pressure dropped from 176/72 to 114/52, and they feel lightheaded and dizzy. Which of the following would be the most appropriate action to take? A. Decrease the ultrafiltration rate. B. Increase the ultrafiltration rate. C. Start dobutamine infusion at 5. Or D. Give a 500 milliliter fluid bolus. The answer is A. Decrease the ultrafiltration rate. And ultrafiltration means fluid removal. So if a patient starts getting very hypotensive, we would want to slow down how quickly we are removing that fluid. And that will help decrease the amount of fluid shifting in the body. So let's slow it down and see if they respond. Question number 6. A patient developed AKI after GI bleeding secondary to esophageal varices, wherein he lost 2 liters of blood. Which of the following lab results would he be expected to have? A. Low urine osmolality and low urine sodium concentration. B. High urine osmolality and low urine sodium concentration. C. Low urine osmolality and high urine sodium concentration. Or D. High urine osmolality and high urine sodium concentration. The answer here is B. High urine osmolality and a low urine sodium concentration. So this patient has volume depletion secondary to upper GI bleeding and most likely is experiencing pre-renal failure due to the hypovolemia. And initially, volume depletion will result in acute pre-renal failure, and the basement membranes of the renal tubules are not affected if treated promptly. And in pre-renal failure, the renal tubules can still concentrate urine and hold onto sodium. So in a dehydrated state where we probably aren't going to be making much urine and it's going to be quite concentrated, we are going to see a high urine osmolality. And since our renal tubules are working, they are going to be holding onto sodium in the body, so there will be a low concentration of sodium in the urine. Pre-renal failure is the most common type of acute renal failure, and it occurs when perfusion to the kidneys is reduced. Pre-renal, meaning that the injury occurs before blood reaches the kidney. And this can be due to a variety of causes, but they're generally all related to hypoperfusion of the kidneys. So if you have impaired cardiac performance, such as with heart failure or an MI or cardiogenic shock, if you have a patient who is vasodilated from sepsis or anaphylaxis, or if they're too vasoconstricted, such as with pressors or as a compensatory response, your kidneys are not going to get adequate perfusion. Or lastly, the big one, when patients are hypovolemic and they are volume depleted, whether that is through dehydration, hemorrhage, or excess diuresis. Again, all of these causes are due to lack of adequate blood flow to the kidneys, aka hypoperfusion. In regards to labs, same with all types of renal failures, we're going to have an elevated BUN and creatinine. And in pre-renal failure, you have to know that the BUN to creatinine ratio is going to be high. It's going to be 20 to 40 to 1. There will be a high urine-specific gravity and urine osmolality because the renal tubules are still able to concentrate urine. And there will be a low urine sodium because the renal tubules are not destroyed, so they will hold on to sodium because the kidneys are smart. They know that if they hold on to sodium, they're going to hold on to more water as a result, and that's exactly what they need to help that hypoperfusion situation that we're dealing with here. So our treatment is going to be treating the cause as always. We will usually be giving fluids because, again, we have some sort of hypovolemia or hypoperfusion. We also want to make sure to maintain a MAP greater than 65 to maintain that perfusion to the vital organs. We want to improve cardiac performance so that we can get better perfusion, and we want to avoid nephrotoxicity, so avoid nephrotoxic medications such as NSAIDs, certain antibiotics, contrast dyes, etc. We want to make sure that we treat pre-renal failure promptly so that it does not progress to intrarenal failure. Question number 7. A patient has acute renal failure secondary to septic shock, had prolonged hypotension, and now requires hemodialysis. His BUN is 90 milligrams per deciliter and his creatinine is 9.2 milligrams per deciliter. Which of the following findings would the nurse expect this patient to have? Is it A, low urine osmolality and low urine sodium, B, high urine osmolality and low urine sodium, C, high urine osmolality and high urine sodium, or D, low urine osmolality and high urine sodium? The answer here is D, low urine osmolality and high urine sodium. So are we looking at a patient in pre-renal or intrarenal failure here? We're actually looking at intrarenal failure or acute tubular necrosis here. And why is this not pre-renal failure? The prolonged hypotension seems like it would make a great case for hypovolemia and hypoperfusion. However, this patient is now requiring hemodialysis, which should lead us to believe that their kidney failure is more severe. And the treatment for pre-renal failure is usually fluids and not dialysis. Whenever you have a BUN and creatinine value, quickly calculate the BUN to creatinine ratio, which can be a huge help in these questions. So our BUN to creatinine ratio here would be about 10. You just have to divide 90 by 9.2. A BUN to creatinine ratio of 10 to 15 is associated with intrarenal failure. And in intrarenal failure, the tubular basement membrane is damaged. And this damage means that the renal tubules are no longer able to concentrate urine or hold on to sodium. In such a case, we'll have a low urine osmolality and a high urine sodium. Acute tubular necrosis, also known as ATN or intrarenal failure, is the worst type of kidney injury that you can have, and it results in damage to the basement membrane of the renal tubules with actual structural damage. And it usually, but not always, will result in the patient needing renal replacement therapy. Some cases of ATN include pre or post-renal failure, which ends up progressing to intrarenal failure. It can be due to contrast dye, nephrotoxic medications, infection, rhabdomyolysis, or surgery. And these patients are unable to excrete fluids and metabolic wastes, so their BUN and creatinine will both be elevated, but their BUN to creatinine ratio is going to be 10 to 15 to 1. They will have a high urine sodium, and that's because the tubules are damaged and they're unable to hold onto that sodium, so you just urinate it out. And they will have a low urine-specific gravity because, again, their kidneys are not able to concentrate urine. The treatment here is going to be to minimize the damage to the kidneys. So we want to prevent acidosis, electrolyte imbalances, and uremia. We want to adjust or stop nephrotoxic medications such as these listed below. So NSAIDs are a huge no-no, antibiotic, ACEs, ARBs, IV contrast dye for sure, and overusage of diuretics. Lastly, we definitely want to assess the need for dialysis in these patients because most patients in acute tubular necrosis or intrarenal failure are going to need it. So I did summarize both prerenal and intrarenal failure here in this chart. You can take a look at this yourself, but most importantly, your BUN to creatinine ratio in prerenal failure is going to be higher. It will be 20 to 40 to 1. And in intrarenal failure, it will be 10 to 15 to 1. Your urine sodiums will be low in prerenal failure, again, because those renal tubules are still able to function, so they're holding on to that sodium. And in intrarenal failure, the opposite is true. They can no longer hold on to sodium, so they will urinate it out. And the treatment for prerenal failure will usually be fluids, while the treatment for intrarenal failure or ATN will usually be dialysis. Question number 8. You are taking care of a patient on CRRT when you notice blood in the effluent bag. Which of the following is the most appropriate action in the situation? A. Continue CRRT as this can be a normal finding. B. Continue with dialysis and check an H&H. C. Stop the treatment and disconnect the circuit. Or D. Stop the treatment and return the blood in the circuit. And the answer here is C. Stop the treatment and disconnect the circuit. So blood in the effluent bag means that there is a membrane rupture. Unfortunately, you're going to have to disconnect the circuit and you do not want to return that blood. So they are going to end up losing that blood that's in the circuit. And since they will be losing about 200 milliliters of blood by throwing away that circuit, it might require extra interventions such as checking an H&H or transfusing PRBCs. The criteria for CRRT is the same as for hemodialysis, which we discussed earlier, so this AEIOU criteria. But CRRT is used exclusively for patients with hemodynamic instability who cannot tolerate these rapid fluid shifts, and they need a slowed down continuous version. So depending on what it's used for, CRRT can filter waste products or remove fluid through an artificial kidney machine. It does require a central line, and complications include those similar to hemodialysis. So hypotension can occur, You can, in this situation, turn down the blood flow rate and see if it improves your hypotension. It can also lead to complications of bleeding, hypothermia, the filter can clot off, and more specifically with CRRT, there can be a membrane rupture, in which case, again, disconnect that circuit and do not return the blood to the patient. Question number 9. You are going through discharge instructions with your patient who is hospitalized for acute kidney injury. He asks you if there are any medications he should avoid when he goes home. You tell him, A, you should avoid NSAIDs, B, you should avoid opioids, C, you should avoid acetaminophen, or D, you don't need to avoid any medications. So the best answer choice here is A, you should avoid NSAIDs. Why? Because NSAIDs are nephrotoxic. Question number 10. Which of the following is known to result in the highest incidences of death for patients with CKD? Is it A, a wound infection, B, dehydration, C, fluid overload, or D, hyperkalemia? And the answer is A, wound infection. Infections are the leading cause of death for patients with both acute and chronic kidney diseases. The other choices are complications of chronic kidney disease, but they don't cause the greatest number of deaths. Moving on along to question number 11. A patient with CKD has a hemoglobin of 7.2, BUN of 40, creatinine of 3.4, and a potassium of 4.6. You should anticipate which of the following? A, immediate hemodialysis, B, epoetin alpha administration or EPOGEN, C, 2 units of packed red blood cells or PRBCs, or D, insulin and glucagon. The answer is B, epoetin alpha administration or EPOGEN. Patients with CKD are anemic at baseline, and the use of EPOGEN acts as erythropoietin, which plays an important role in making red blood cells. It helps control the anemia and reduce the number of blood transfusions that patients require. There really is no indication for PRBCs as, for one, their hemoglobin isn't lower than 7, and 2, it also doesn't give us information about their hemodynamic stability or if they're symptomatic, so we're not really going to read into the question too much. Hopefully, with the administration of EPOGEN, the patient's hemoglobin will be stable and they won't require that transfusion. Chronic kidney disease is defined as the slow, progressive deterioration of renal function and a reduction in GFR. Patients who have diabetes, hypertension, autoimmune diseases, and chronic exposure to nephrotoxic medications are all at higher risk of developing chronic kidney disease. And as far as labs go, we will certainly be seeing a high BUN and creatinine in these patients. They will also have high potassium, magnesium, and phosphorus because their body is not able to get rid of the electrolytes appropriately. There will be low levels of calcium. They will generally be on the lower end of pH, and they will have low levels of protein and anemia. Our treatment here is going to include medical management of the chronic kidney disease and dialysis. But we do want to absolutely educate these patients on the importance of lifestyle changes to eat healthier and to move more, which could help not only their kidney disease, but their diabetes and hypertension as well. Lastly, we want to prevent infections, since infections are the leading cause of mortality for patients with kidney failure. Question number 12. A patient is admitted with a diagnosis of acute tubular necrosis. Which of the following findings would this patient be expected to manifest? A. Hypermagnesemia, acidosis, and hyperkalemia. B. Azotemia, hypocalcemia, and alkalosis. C. Hypokalemia, acidosis, and hypertension. Or D. Hyperkalemia, hypomagnesemia, and acidosis. The answer is A. Hypermagnesemia, acidosis, and hyperkalemia. So azotemia is absolutely present in acute tubular necrosis. Azotemia is the rise in BUN and creatinine levels, but it's not listed here with the correct answer. The correct answer is A, because the kidneys are not able to effectively excrete potassium and magnesium, so patients will be both hypermagnesemic and hyperkalemic. And they're going to have acidosis because their bicarbonate regulation is lost. So again, the correct answer here is going to be A. Question number 13. Which of the following patients will most likely need hemodialysis? Is it A, the patient with a BUN of 88 and a creatinine of 3.8? B, the patient with metabolic alkalosis and hypokalemia? C, the patient with an aspirin overdose, a BUN of 15 and a creatinine of 1.5? Or D, the patient with a serum potassium of 5.8 and a normal EKG? This is kind of a tricky one, but the correct answer here is C, the patient with an aspirin overdose, a BUN of 15, and a creatinine of 1.5. So we want to think about our AEIOU criteria. A stands for acidosis. Well, none of them say acidosis, but B says alkalosis and hypokalemia, so we can cross that one out because we know that high levels of electrolytes will be associated with kidney injury and acidosis. Remember, when you take acid, you get high. If you don't know what I'm talking about, listen to a couple of my other lectures. Choice A sounds pretty enticing with a high BUN and a pretty high creatinine. However, let's look at the BUN to creatinine ratio. 88, we can round that up to 90, and 3.8, we can round that up to 4. So if 80 divided by 4 is 20, then 90 divided by 4 is going to be a little bit higher than 20. So we're going to be looking at a BUN to creatinine ratio that is greater than 20. Is this prerenal or intrarenal? BUN to creatinine ratio greater than 20 is prerenal. And we know that prerenal injury comes before the kidney, which means that it's probably coming from hypovolemia or hypoperfusion, and they will probably need fluids and not dialysis. If the BUN creatinine ratio is closer to 10 to 1, that would alert us to an intrarenal injury and it would require dialysis. When you get these questions, quickly find out the BUN to creat ratio to help guide you through your thought process. Now, the patient described in choice D has hyperkalemia but no EKG changes, so we can deem this patient stable and try other interventions to bring the potassium down. So that leaves us with answer choice C, because a salicylate overdose, aka aspirin overdose, will cause metabolic acidosis, renal failure, and tubular membrane damage if not treated promptly. Question number 14. Which of the following would be expected for a patient with renal hypoperfusion? A, urine sodium greater than 20 and serum osmolality greater than urine osmolality. B, urine sodium less than 20 and serum osmolality greater than urine osmolality. C, urine sodium greater than 20 and urine osmolality greater than serum osmolality, or D, urine sodium less than 20 and urine osmolality greater than serum osmolality. The answer here is D, urine sodium less than 20 and urine osmolality greater than serum osmolality. I know I've been through this before, but we have renal hypoperfusion. What kind of kidney injury is this? It is a pre-renal kidney injury. The renal tubules are not yet destroyed in pre-renal kidney injury, so they can concentrate urine and they can hold on to sodium. So in a dehydrated state where we're probably not going to be making much urine and the urine will be concentrated, we will have a high urine osmolality. And since our renal tubules are working, they're going to be holding onto that sodium in the body. There will be a low concentration of sodium in the urine. Question number 15, your patient is lethargic. Her mucous membranes are dry. She has dark amber urine. Her urine specific gravity is 1.035. Her BUN is 65 and her creatinine is 3.0. Her vital signs are a temperature of 38 degrees Celsius, heart rate of 130, respiratory rate of 24, and a blood pressure of 90/40. Which of the following should the nurse anticipate administering? A, antibiotics, B, hemodialysis, C, isotonic fluids, or D, furosemide. The answer is C, isotonic fluids. First thing that should jump out at you is that you have a BUN and creatinine. So let's look at our BUN to creatinine ratio. It's actually close to 30. That should alert us to pre-renal failure. Her vital signs are most likely due to hypovolemia and dehydration. So administering isotonic fluids will restore that vascular volume, increase the urine output, and correct the tachycardia, hypotension, BUN, and creatinine. Last but not least, I threw in a bonus question. So a patient with acute tubular necrosis is differentiated from a patient with pre-renal failure in that only with pre-renal failure is A, the urine specific gravity low, B, the urine osmolality is low, C, the BUN to creatinine ratio is at least 20:1, or D, the urine sodium 40:100. I know it takes a second to kind of think through these choices, but our answer is C, the BUN to creatinine ratio is at least 20:1. All right, guys, we have made it to the end. If you liked the video or you found it helpful, please like and subscribe to my channel. I would greatly appreciate it. Let me know if you have any questions. I would be more than happy to help. Good luck to anyone taking the CCRN. You can absolutely do this, and you've got this. Thank you everyone for watching. Nurse Jenny signing off for Nurse Life Academy. Have a good one.